So in the chat, are you more familiar with the terminology of PAM, primary acquired melanosis, or with conjunctival intra-epithelial melanocytic?
We've got a bunch of PAMs,
Yep, a bunch of PAMs, that's what we thought. And my clinicians also are very PAMish. However, you should be aware that the nomenclature has changed, and since you're the new generation, it's got to move with the times. So it's now in the WHO, which is what we follow for standardized nomenclature around the world, is conjunctival melanocytic intraepithelial neoplasia. Just like we have squamous intraepithelial neoplasia, this is melanocytic intraepithelial neoplasia. One of the criticisms of PAM was that it was not particularly standardized between atypical and non-atypical, and is the atypia mild, moderate, and severe, which has brought in the new system, which is divided up how we describe intraepithelial melanocytic neoplasia, and you can see it's along anatomical subcompartments. So there's three subcompartments: horizontal growth, vertical spread, and then the cellular atypia. So it's trying to be more systematic in its naming. And then in the WHO, this is how it's what do you call it, put into practice. So I have this printed out and glued onto the wall behind my microscope. So we have three different things that we've got to grade, just as I said up here: horizontal, vertical, and atypical. So let's look at the first row: horizontal, radial spread. So we're looking here at the epithelium, and there's no abnormality here. We normally, in all normal people, we have melanocytes scattered, say one cell to every 5 to 10 cells is a melanocyte along our basal epithelium. All the rest of the other cells are squamous cells or keratinocytes. In this one here, we have basal epithelial proliferation. So we have got melanocytes, their little cell bodies are touching each other. Normally they don't touch each other, they only touch their dendrites. So here they're touching their cell bodies, and it's got basal proliferation, but it's restricted to the basal. This is, we were asking about pagetoid before. Now, can you recognize this? Those cells with the retraction artifact around them, those are the melanocytes, and they are doing pagetoid spread up through the epithelium. Normally, they should live in the basal layer. They should not be migrating upwards. So that's an atypical feature. And another pattern in the horizontal dimension, these are nests. It's still intraepithelial. So we're talking about intraepithelial neoplasia. We're not talking about invasive melanoma yet. This is all intraepithelial, IN. Nested form, and here the nests have become confluent. So that's in the horizontal dimension. Vertical, so we look at vertical spread, nothing. And then how far up and down? Remember we talked about basal squamous cells as a percentage of the thickness of the epithelium. So here 1 to 50%, this is where the proliferation is occurring. And here it's up to 90%. These are all abnormal, atypical melanocyte cells. And here it's full thickness greater than 90% all the way up to the top. I'd call that melanoma in situ. And then the degree of atypia. And you see the rule here, nucleus to cytoplasmic ratio. So we compare the melanocyte cell to the nucleus of the adjacent squamous cell. Is it the same size, or is a melanocyte cell bigger, which is abnormal? So I'll just move that up a little bit. Here, the nucleus is greater than or equal to the basal squamous cells. That's abnormal, so you give it 1 score. Here they're getting bigger, and here they're really big. And it's got nucleoli and mitoses. So that's the purpose. As you can see, we've got this matrix, we score it up and you get a score out of 10, and it's more reproducible and systematically standardized rather than just eyeballing it and saying, looks like medium atypia, so more standardized. And this is how it is turned into words. This is the PAM system: without atypia, mild atypia, moderate atypia, severe atypia, melanoma in situ, invasive melanoma. Here we have a C-min score. And then this is the new proposed classification, but you can see how we go all the way from low grade to melanoma in situ to invasive melanoma. Okay, so I'll just pause here. Any questions, Diane? Have you got a question, Diane? What do you use now, or do you use both?
So I'm very translatey. So I don't use PAM anymore. I give them a C-min score, and then I turn it into a low or high grade conjunctival melanocytic intra-epithelial lesion, because really the low grade versus the high grade is what drives treatment. Yep.
Yes. Yep. And you can see this PAM with mild atypia, moderate atypia, severe atypia. It's not quite clear which is high grade and which is low grade. Yeah, because it doesn't have a high-low. It's got this moderate thing going on there.
Yeah, I think I quite like the C-min score because it is more objective. But I like the WHO description of it because it tells people what to do about it.
High, low, melanoma in situ. Yes. All right. So, does retraction artifact mean the same thing as separation artifact? Oh.
Yes.
Yes. So here's some, and here's some, and there's some, and there's some. So all those white spaces.
Yeah.
Good. Right. Okay. So this is an area of what does melanoma in situ mean? There is now a defined definition as greater than 75% of the epithelial thickness. Greater than 75% of the epithelial thickness. So this one up here is greater than 75% of the epithelial thickness.
And it would be.
And how much score? Yeah. And C-min greater than 5 when you add it all up. Okay. Differential diagnosis, junctional nevises. Oh, children, yes. So junctional nevis in children can be very active, particularly around puberty. So that is a common problem for pathologists in particular, probably not so much a problem for clinicians. Yes, if I see it's an adult and there's a junctional proliferation, I think this is in the PAM category or C-min category rather than a Nevis. And this epithelial invaginations, we will have a look in some of our slides. This particularly, that's a feature that you often see in children associated with nevi. And they dip down into the underlying subepithelial stroma. It's not invasion, it's following a normal epithelial lined structure. And here we go, BRAF. So the conjure's in a UV exposed site, and many of the melanomas and melanomas in situ have a UV damage pattern, and therefore many of them have the BRAF V600E mutation, unlike conjunctival, unlike the choroidal melanomas. So conj is more like skin. It's like a skin melanoma. Okay, that's it. Questions now before?
Yeah, we've got a treatment question here. Good. Do you need to treat low grade? With the previous classification, PAM without atypia is benign. Now, I'm not an expert on treatment, so I think we might crowdsource this. If we called it PAM with mild atypia, you're saying it doesn't need to be treated, and PAM without atypia, we've kind of clumped them together into low grade conjunctival melanocytic intra-epithelial lesion. So crowdsource this. So people, does a low grade conjunctival melanocytic intra-epithelial lesion need to be treated?
Yes, no. The other thing is, I think Diane is right at this end of the spectrum. When we have often we get, I get a lot of cases of constitutional melanosis, which is not PAM, and it's it's in darkly pigmented people who have those where the melanin has transferred to adjacent keratinocytes, and it's not a proliferation, but that looks very brown.
Yeah. And telling the difference in eye melanocytes between no atypia and mild atypia is really hard, because if people have, it's hard.
It's hard.
It's hard. Yeah. Okay. So we've had 2 no's, and then without atypia observe and with atypia treat. And then people saying extent in clock hours, though, is the most significant RS for risk factor for transformation. All right, how do we differentiate racial melanosis versus PAM without atypia? In racial melanosis, there is no increase at all in melanocytes. They have a normal number of melanocytes, just an increased number of pigment in the basal layer. It's just like the skin. So the difference between normally pigmented skin and say a junctional lentiginous proliferation is the number of melanocytes. They have the same number of melanocytes.
So PAM without atypia, they give this a Siemens score of 1. But racial melanosis would be 0, 0, 0. They're not atypical, there's no vertical spread, and there's no horizontal spread.
Yeah. Okay.
Right.
Great. I think
we need to actually apply what this is.
Let's do that. So let's apply that. So if we go to, I'll share screen again and go here. All right, so let's look at this PAM.
Number 8.
8. So let's look at number 8 together and look at the PAM and apply it. Okay, I will pop you in breakout groups. Do that.
And maybe the navigator, you can have the
Diane, is HMB45 immunohistochemistry, is that for just melanocytes or does that differentiate melanoma?
Oh, it's just, so it stains melanocytes with thick with lesions that are in the dermis. So you think it's a dermal lesion and you're not sure whether it's melanoma. One thing that we can do is use HMB45 with those, because if they're maturing normally, then they lose their HMB45, whereas if they're not maturing, they have it all the way through. So it's one of the soft signs that we use to tell melanoma from a mimic of it, like a Spitz Nevis. So we do a P67, a P16, which is positive in normal melanocytes, unlike squamous cells, and an HMB45, and we can score those to help us tell the difference between melanoma and its mimics, like Spitz Nevis.
You say P16?
Yeah, so we use P16 in that situation as well, because unusually it's normally present in melanocytes and it's lost in melanoma cells. So I wouldn't worry about this. This is minutiae for pathologists.
Okay.
All right, I'm going.
P16 is not just.
And I'll share this Pam here. And do you want me to talk or do you want to talk there, Amanda?
I can talk.
All right.
And then I see that Chin's asked a good question already. How can you tell the difference between melanocytes and basal squamous cells? It's a very good question. We will go through it. So
people were commenting that this was conj. I'll just let it render.
yes.
But it was on both sides, Amanda. There seems to be a hole in it in the middle here. And so
you're not sharing yet.
Oh, okay. Sorry. Thanks for that.
Amir, can you mute yourself, please?
Yep.
There's some background stuff. Thanks.
All right. Let's share.
That's better. View options. Screen.
Right. Am I sharing now?
Yes. Okay. Right. I see a strip of thin, flimsy material that has been embedded on edge, and it seems to be a mirror image of itself with some stroma in the center. So I think this thin, flimsy piece of material has rolled over into like a C shape, but like a roller blind, and that's why we've got epithelium on both surfaces. Now I want to look closer at the epithelium to determine what sort of epithelium we are in. So because it's so thin and flimsy and it doesn't seem to have any skin adnexal structures, I think it's probably conj, and on the lower surface I can see it's squamous epithelium and there are a few goblet cells scattered around. Yep. So I think this is conj. And then on the upper surface where it's folded over, I see it's brown. So I think the clinician has excised a pigmented conjunctival area. And so my job is to determine what's the cause of this. Is this racial pigmented nothingness, or is it a melanoma, intra-epithelial melanocytic proliferation? So in this field here, I can see that the brown cells, so that have increased pigment in the cytoplasm, and some of them have a retraction white space around the outside. And I know that that is a morphologic feature of melanocytes. So I think there are melanocytes that have proliferated along the basal layer in this field, and they're touching each other, and that's abnormal. And this is part of the lesion that's been excised. So if I bring up that C-min matrix, then it's not, the radial spread is not zero. In this field here, it's at least basal, number one, which looks like lentiginous to me. And then I can see that there has been there's some pigmented cells further up in the epithelium. Now they could be either keratinocytes, or some of them may also be melanocytes. If they've particularly got that retraction artifact around them, then I would think that they would be melanocytes. And if there are melanocytes further up in the epithelium, then that would be evidence of pagetoid spread. I think in one of the other pieces on the down surface, there was a higher grade, yes, this area of change. And I want to grade on the worst area to get the highest grade.
So I would have called that score 1 for basal, score 1 for vertical spread, and score 1 for
atypia.
Yeah, so I would have scored that particular bit a 3.
But wait, there's more.
All right, where do you want me to go, Amanda?
So in the field that you've got there, if we zoom in, that particularly darkly pigmented area.
Area here?
Yes. So looking at this, it's much, it draws my eye because there is a lot of pigmentation in the cells going on here. And I can see at least one, and I'm suspicious if you move down a little bit, I thought there might have been some pagetoid spread with some melanocytes moving up away from the basal epithelium. So it's variable. So like there's one that's not touching the basal epithelium. Stop there. I think there's one there.
That one.
Where's your little thing? There, stop. There, that one. That one.
Yep.
Yeah, he's not touching anymore. So I'd call him at least pagetoid, but I don't see nests yet. So if I'm doing radial scoring, I'm going to call this one pagetoid number 2. Wow. Now I'm thinking about vertical spread. So I want to look at the worst area. Now, although this is the worst area, I'm a little bit suspicious because it's so thin that we haven't got the full thickness. Maybe some of the surface epithelium has been lost artifactually, but it's at least, it's above the basal layer, the vertical spread. So it's at least score 1. And if this was the full thickness, it would be greater than 50%. So I'm not quite sure if it's the full thickness or not. What do you think, Diane?
I thought the top might have been lost as well because it's not maturing normally. I would have put this at about 50%.
50%. So 1 to 2. Yep.
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 Yep. And the nuclei?
And the nuclear atypia. So that's when I look at the size of the nuclei of what I think are the melanocytes, which have dense pigment and a bit of a retraction artifact around them, and I compare them to the basal squamous cells. Squamous cells have eosinophilic cytoplasm and they have prickle cells around, prickle layer around them. I think it's at least the same size, and I'm suspicious that some may be, yeah, so at least the same size as 1. Yes. Maybe, yeah. So I'll give this pagetoid 2, vertical spread 1 to 2, nucleus 1 to 2. So I would give this
severe.
Yeah, 4 to 5. I want it to be in the severe group.
4 to 5.
Yes.
4 to 5. So it's high grade conjunctival melanocytic intra-epithelial lesion.
It's high grade, yes. So it should be taken seriously. I would need to look at the margins, but because this is rolled over, I can't actually assess the margins, and I'd look for invasion, and I don't see any invasion. So those are my prognostic factors. And Alice asks, can cells other than melanocytes be pigmented? What do you think, Diane? What about that racial pigmentation thing?
Yeah, so the job of melanocytes is to transfer pigment to other cells. So unfortunately, yes. So for we have a SOX10 marker that we can use to identify the melanocytic cells. But if we use the usual immunohistochemistry, it would stain them brown, which isn't going to be useful here. But fortunately, we can stain them red. So if I was ever worried about whether they were basal cells or anything, I would use the SOX10 red to identify the
and when you say basal cell, do you mean basal squamous cell or do you mean basal melanocyte?
I meant basal squamous cells, yeah. So we can identify, even when it's very pigmented, we can identify melanocytic cells.
Perhaps you can zoom in a bit closer so we can just have a mental picture to link to that. Because I think on the surface, away from that area of atypical cells, there was some transfer of pigment into adjacent epithelial cells, which is normal.
Like that here.
Yeah.
These are the melanoma cells with their clearing, and these are normal squamous cells. Like here's some normal cells that have got pigment in them.
Yeah, so, and I think all of those ones are melanoma cells, melanoma in situ cells. And yes.
Does the pagetoid spread imply leaving basal cell layer versus vertical spread mean it's still collected to the basal layer? I think that would be a really good definition. And then, are we meant to memorize the grading table? No. Or why do we call them squamous cells? Because the conch has squamous cells in it. It's a squamous mucosa. It's a non-keratinizing squamous mucosa with goblet cells mixed in with it. So right, not columnar. No, it's not columnar. It's a squamous mucosa.
Because conjunctiva comes from, when you think back to when you were a trilaminar embryo, you had 3 layers. You've got your ectoderm, your mesoderm, and your endoderm. So the surface of your eye is your ectoderm. It's continuous with the skin. So whereas your gut, which is columnar, is the endoderm. This is ectoderm squame.
Can we please differentiate between the pagetoid spread and the squamous cells with pigment in it? All right, so the pagetoid spread, abnormal nuclei. whereas the squamous cells with pigment in are the normal nuclei. They're bigger and darker. It's pretty subtle.
Yeah, it is a bit subtle, Diane, isn't it? But
Yeah,
we get used to it. So
it is. I think if you were able to suggest that this was Pam and talk intelligently in your prognostic factors about horizontal spread, vertical spread, and nuclear pleomorphism, you would be home.
yep, you'd get all the right marks for talking about the right things.
And even if you, yeah, and then you would say something like this is a confluent spread, and with nuclear atypia, I think it's in the high who stuff, yeah, and the who high grade. The darker nuclei equals basal layer squamous cells. Well, the very dark nuclei are going to be the melanocytes, these hyperchromatic ones, and the medium dark nuclei are going to be, yeah, let's try and find a normal bit.
Just, yeah, what about on the other side of the same field there, where we've got a normal
Normal,
conj?
right. These are the basal cells. Actually, it's not quite normal because I think we've got some atypical melanocytes here as well. Let's just find some normal. Right, this is normalish. Here we go. So these are the basal cells here, right, and these are the squamous cells, and this is the start of a goblet cell. But even this here,
Basal cells are still a type of squamous cell.
yeah, they are. Yeah, they're basal squamous cells. Yeah.
Mm-hmm.
Yeah. Okay.
It is a bit confusing, isn't it? Nomenclature.
It's a bit confusing. All right. So now we come to the teacher-led bits, don't we?
Okay, so we're going to talk about one first,
I think,
which will be number.
I think in the interest of time, we should just compare and contrast the Nevi and the
number 6, yeah.
6 and number 7.
Mm-hmm.
Okay, so we're still recording. That's good. Go back to the schedule. I will open number 6. Make that big. And I will, oh, that didn't work. I'll just zoom in a minute and then open number 7. Or number 6, number 7. Right, so this is number 6. All right, let's run through the rubric here. So we have conjunctiva and it's folded over again. Is there a way to stop them folding over, Amanda?
Yes, there is. So it's in how to send specimens to the laboratory, for which I had made a video and linked to YouTube, which is one of your homeworks from 2 weeks ago. So how do you do that? Type into the chat box, because this is a really good short answer question for your exams. How to send thin, flimsy specimens to the laboratory.
So we've got
Yes.
mount on card, spread on cardboard, mount on card, put it on cardboard, but other things like filter paper or blotting paper work as well. Just anything that will adhere, and then put it in formalin, face down.
Yeah.
Floats on the top, face down.
Yeah.
All right, so we've got conj, and I can see some normal structures here. I can see normal conj here with its goblet cells, and I can see these glands here. So they're not really glands, they're really invaginations of the conjunctiva, aren't they? So they're called the,
I can see little holy things all the way along that basaloid proliferation.
Yeah, here we go. So the glands are intact and are being surrounded by things, and they're good big glands. So this is a post-pubertal kind of conj. Yeah. And then we've got cells here in the stroma. So what kind of cells are they? They are pigmented cells. So I'm thinking that they're melanocytes because they've got quite a lot of pigment with them.
They don't look that pigmented to me. They just look blue. How do you know they're pigmented?
There's a bunch of pigment around them where they've dumped it out, but some of them are pigmented, like through here. So some of them have just dumped their pigment as they do into the surrounding, but some of them are still pigmented, like these ones here.
Okay.
And so I also noticed they're arranged in nests, which is also typical of melanocytes. So I'm pretty sure that this is a melanocytic proliferation here. in the conjunctival stroma. And out here, I noticed that there's some that are here adherent to the surface. So this is probably going to be a compound lesion where we've got some junctional activity around here and also some in the stroma. So I think I'm either looking at an invading melanoma or I'm looking at a compound nevus. So I have to tell the difference here between a melanoma and a nevus. So the first thing I do is I go back to low power because it's really helpful to see whether it's symmetrical or not. So I do notice it tailing off towards the edges and bulging in the middle. It's got a vaguely symmetrical look to it. I'll go very low power, so symmetrical. My friends with lymphocytes who are really good at detecting malignant things aren't present, so there's no lymphocytic infiltration. And then we're left with, is there any mitoses or pleomorphism? And the thing with eye lesions is because the eyelid's rubbing over them a lot, they get quite a lot of pleomorphism in them anyway. So this cell here is quite different to these cells here, yeah? But they are still within the acceptable range. So the pleomorphism that you get in eyelid lesion cytology is much, much greater. But if I look closely, I can't see mitoses here. But it's really confirmed at low power. And mitoses are hard to spot. Yes, Amanda?
What about nucleoli? Is that useful?
Looking for nucleoli is useful. In these, there are no nucleoli. There's maybe a dark blob here in this one, but mostly there aren't nucleoli. So nucleoli is medium useful because sometimes you can get some nucleoli in some cells, but if all the cells are large and epithelioid with bright pink nucleoli, you know that you are on the melanoma train.
Mm. Is there anything up there in the epithelium? Is there any abnormal melanocytes in that epithelial layer?
So we have some melanocytes at the junction over here, but they aren't doing a pagetoid spread or extend up thing. But it is quite darkly stained. So I would say that we have a basal proliferation of melanocytes, but they aren't extending up.
Okay.
So it would be unusual to have a melanoma. Actually, here's a little nest. Sometimes it's folded over and it's really hard. It would be unusual to have a melanoma that was so symmetrical, not attracting lymphocytes, having no mitoses, preserving the glands. They aren't destroying them, they're just moving around them and having a good going PAM next to it. Shall we have a look at the melanoma now for compare and contrast? Right, so here's a melanoma. So at low power, I'm noticing a lack of symmetry. Okay, so here we have this melanoma, this lesion, which is asymmetrical. You can see that it's tailing off here. There's not like a tail on the other side, so it's asymmetrical at low power. It's forming this really big mass. So nevi don't often form really big masses. They're often quite flattish things. And it is a destructive invasion. The normal glands have gone. Around the edge here, we're getting some really nice pagetoid nests moving up. This is great pagetoid spread, which would indicate that there was associated.
Oh, yes. Yeah. I can see that now.
Yeah, there we go. And then when I look at these cells on higher power, they do have the really, really big nucleoli, don't they? Here we have nucleoli, and this looks like a really terrible cell. So this falls into that like super sized cytoplasm and nuclei. So these cells have got marked pleomorphism in many of the cells. So this is super pleomorphism. So I would say this was markedly pleomorphic. I find mitoses quite hard to find in these melanomas sometimes. But, it's best. Nishan says,
oh, don't they also look foamy?
Yeah, unfortunately they do. So this could be a sebaceous carcinoma, couldn't it? So we'd have to do some immunohistochemistry here. So that's a really good point.
Where's the pigment, you see? So,
yeah, so this could be an amelanotic melanoma, differential diagnosis, sebaceous carcinoma. So my differential diagnosis here would be sebaceous carcinoma or basaloid squamous cell carcinoma.
And malignant melanoma.
Yeah, oh, sorry, malignant melanoma.
Yeah.
I'm just looking because there's a little nerve here that I'm a bit, is that a nerve? Might be a nerve, right? Perineural invasion.
Just waiting for that to render. I think it's just at the top. Oh yes, that's a little nerve. Yes, yes. So that's axons looking directly end on.
Yeah. It's got perineural invasion. I would have to do immuno on this to make sure it wasn't a sebaceous carcinoma, or find a bit that had super duper pigment in. So at the moment we've got an invasive nodule that's really pleomorphic and mitotically active. Is there something not over here? Yes, I've got to look around for it.
So Chin's asked the question. In fact, why? How about we can the team answer Chin's question? What do you think? Is perineural and perivascular invasion prognostic factors for melanoma? Is it prognostic factors for anything?
Says Nish. Yep. Okay.
So you can always put down perineural and vascular invasion.
I think these epithelioid cells would be quite unusual for sebaceous carcinoma, but I would definitely be piling out the SOX10 and the adipolipidin.
Yeah, androgen receptor. Yes, because actually it's not pigmented at all. Is there any brown stuff? I don't see any brown stuff.
Amelanotic melanoma. Let's have a look at this other bit. Yeah. Here, is there any pigment over here? Okay, so I put these two in together so that you could see the difference between melanoma and Nevis cells. Which we are, because they're just like really horrible. And then here again is this PAM on the top. There's a beautiful cell with a giant nucleolus. This is very typical morphology for a melanocyte. Yeah, so good differential diagnosis seeking there. All right, is it excised? No, I don't think it's excised here. I think it goes to the margins. But I would have a look. I think the PAM might go to the margins. Yes, it does. Are there any more questions on these two?
There we go. So Luke's saying without pigment, he doesn't think that he would go straight to that diagnosis. And that's, I would agree with that. Yeah. And can you without specific features that would go down that pathway?
Yep. Yeah, I kind of leapt on those epithelioid cells when I shouldn't have. I probably should have been a bit more open to that possibility of it being particularly a sebaceous carcinoma.
Yeah, so malignant neoplasm, because we haven't yet determined whether it's melanocytic line or epithelial line.
Yeah.
So, and we would only do BRAF. When would we do BRAF? Well,
right. So we would BRAF's not a prognostic factor. BRAF is a treatment-related immuno, not a prognostic factor and not a diagnostic immuno. So we would do BRAF when it met the criteria for it. So at the moment, BRAF funding is only available for stage 3 melanomas and above. So we wouldn't do it immediately. For skin, yes, for skin.
And you'd have to prove this is a melanoma in the first place.
So the first step is to prove it's a melanoma, and then to stage it properly, you know, because they might want to do sentinel nodes or something, or it might end up in an exenteration with it going to the margin there. Who knows? It might have. They might want to do sentinel nodes, and only after it's been staged properly would we do a BRAF.
Yep.
Can BCC be a differential diagnosis?
No, I don't think so. In this case.
or
No.
any retraction. And
it's also got that spread up into the epithelium, the pagetoid pattern. Yeah.
So IHC, yes. So the principles of IHC with these lesions is rule in and rule out. So I would do at least 2 melanocytic markers, and I would probably do I would do SOX10 because it's the most specific, and then I would probably do HMB45 because I just like it, or Melan A or S100. So out of those 4 melanocytic markers, I would choose 2, and then it's ruled out. So I would also choose the things that would rule this out. So I would do an epithelial marker, like a cytokeratin, and then a specific one for the androgen receptor or adipolipin. Would I do an EMA? No, it's I probably wouldn't. I would choose a cytokeratin,
and then Jeff asking about perineural invasion, requiring cells within the nerve or just surrounding the nerve?
Perineural, around the nerve. Otherwise, it's intraneural invasion.
Both are bad. Okay, good. Right. How are we going for time?
It's 2 o'clock, it's 5 to 2. So should we? I'll stop sharing. I know that I've seen that Michelle has arrived. Should I'll go and have a little chat to Michelle
good.
And see what time she's available to start. Otherwise,
you can start now if you want. I'm here.
We'll do the cornea afterwards.
Yeah, we can do that, and so Michelle can get her thing done. Do you want to have a little stretch break for 30 seconds?
5-minute stretch break. I'll make another cup of tea. Hand over to Michelle.
Yeah, let Michelle get her screen up and all that sort of thing. So starting at 2 o'clock New Zealand time.
Yep. We'll
calculate backwards.
Well, and then during that time, I will download a bunch of stuff, and then.
Okay, so we'll start on the hour.
Start on the hour.
Everybody get up and move around.
Yeah.
Otherwise, you're going to have sludge in your brains. So.
Is that okay, or is that on the presenter view, Diane?
That's on the presenter view.
Okay. No way it does that. I'm trying to.
Did you get a good thunderstorm at your place, Michelle?
Yes, lots of rain.
Right, yep. So Michelle's busy sharing there. Good. Right, that's perfect. I can see you and the screen.
No, not the presenter view?
Yeah, not the presenter view. I can see. So sorry. It's perfect like that.
Perfect. Okay, cool.
Perfect. Off you go. It's perfect. So yeah, we'll give them another 3 minutes and then we're good.
Hey, Michelle. We're just wondering if there were any PowerPoints that was shared for your slides today, or
yes,
you'll share them afterwards.
Yeah, I'll put them afterwards. I just I can't find the link to Google Classroom because my computer shut down and I had
No
it all
problems.
over. But I will. I'll post it up straight after.
Thanks so much, Michelle.
No worries.
Also, Michelle, if you don't mind me asking, do you know any good resources to practice MCQs for genetics?
Yeah, I mean, I've put a few more in this one, and there are. I think Diane had a link to some, but they were quite difficult ones. I think they were more like the kind of like calculating family risk.
Yeah, took me a while to get through them.
And I think a lot of the stuff that we've gone through should be stuff that will come up. I think the inheritance stuff is basic things. So like go through the recessive and the pedigrees and look at the things like recessive is like if there's 2 carrier parents that it's 1 in 4. With the trisomies, just look at what a translocation is. Be able to describe maybe what a translocation is if it's a 46 whatever. I recognize whether or not it's a trisomy because it's got +21 written. Those sort of things they might ask you. Hopefully they shouldn't be. I've put a few about some of the techniques in this one. Looking at the curriculum that you got, some of it seems quite outdated, like things like LOD scores and stuff. Like I haven't done it for like ages and ages, but I'll put one in this presentation now and some questions and what I think they can ask you or likely.
Okay, cool.
This presentation will have a few more MCQs in it, and I'll have a think about some other resources that you could use. But you'll probably be fine. You probably know it all.
Okay.
Be okay.
You have a lot of faith in us. Yeah, because there's quite a lot of stuff on like the types of sequencing and the techniques, and I was just wondering like what kind of detail do we need to know?
Not very much. And so again, like with the sequencing, it's kind of when it's used and what information it would tell you, I think would be more important with knowing the difference between a technique that's looking at DNA rather than proteins, knowing that blots tend to be hybridizing as opposed to looking at individual sequence, that mutations are different techniques and what they're used for. And again, I'll go over some of that today. But and PCR, there's I think probably lots of questions come up on PCR because it's kind of a big thing. And again, the level is just really what it's used for. So understand that PCR is used to amplify DNA. And I'll go through just roughly how it works. But I don't think you need to memorize as to be able to write a short answer question on that. I don't think. I think the short answer things maybe would relate more to stuff like today to do with apoptosis and to do with maybe cell cycle. But I don't. But it would have to fit in with a cancer that's relevant that you to the eye as well, I guess.
Cool. Thanks so much, Michelle. Appreciate it.
No worries. When are the exams?
It's in about 4 weeks.
4 weeks. Okay. So I'll have a look for some more MCQs as well and I can post those up.
Perfect. Thank you.
So, Michelle, will there be a lot of calculation questions like the population genetics?
No, that was just me.
Okay.
I don't think that they would. That would be mean if they gave you something like that. I think that they, at worst, I would say they would ask you. I mean, I don't know because this is not my area, so I don't know what they want UI people to know. But I would think at worst,